I am a neurointerventional radiologist. I work primarily at St. Mark's Hospital, but work for a radiology group that covers a lot of HCA hospitals around, including Lone Peak. And I am sort of a brain plumber. If you think about mostly what a cardiologist does, we do that in the brain. And there's been huge advancements in our field recently. So I wanted to share some of the stuff that I'm able to do in my practice now in Utah, and that is sort of changing in our field. So we're going to talk today mostly about ischemic stroke. And I've been in Utah about a year and had the opportunity to treat some very interesting patients, and want to share what we do in the HCA hospitals that make us, I think, unique and faster than other folks. So there are two types of stroke. So stroke means sudden onset neurologic deficit, and it really is a clinical diagnosis. That word is more and more common in the popular media. We're putting up billboards. The American Heart Association, et cetera, are trying to really have early recognition of stroke because there are powerful interventions, probably the most powerful interventions in all of medicine that are available. Most strokes are caused by a blockage in a blood vessel. They're ischemic strokes, and that's about 87% of strokes. So this is a graphic showing the middle cerebral artery here, and if there's either plaque or, more commonly, embolic material from the aortic arch, from the heart, blocking these main blood vessels, that presents as acute hemiparesis in the contralateral hemibody. Additionally, about 13% of strokes are hemorrhagic or bleeding strokes, and this is excluding trauma and other causes. So today we're really going to be focusing on ischemic stroke, which is much more time sensitive. So I know you guys get a lot of calls for neurologic problems, and it's hard to differentiate what's severe and what's not, but using CSTAT to try to get a severity of the ischemic stroke and really trying to ferret out somebody's last known well time is important. So when we look at ischemic stroke prevalence in the United States, we see the southern United States as the stroke belt. And there's lots and lots of strokes here. There's high rates of diabetes, obesity, smoking, kind of from, Texas all the way to the eastern seaboard here. So I came from New Mexico, where we actually have a lower stroke rate per capita, which is kind of interesting because there's lower life expectancy rates. So here we are in Utah, kind of middle of the road. But we have an older population, and people tend to live a long time in Utah, maybe even 10 years longer on average health span than some southern states. So people have strokes, though, because there's older folks, and it still is somewhere between the third and fifth leading cause of death, depending on where you live. Any idea? The answer is red here, so we kind of gave it away, but there's 800,000 ischemic strokes per year. So this is a big problem. It's the #1 cause of disability in our society. We've had lytics for, 20, 25 years, but the onset of mechanical thrombectomy or clot removal is really changing stroke survival. And now it's an access issue. So we depend on you guys, on EMS, to get these patients to the hospital. This is a very time-sensitive problem. 1.9 million neurons are lost every single minute, and billions of synapses. So an hour of stroke without treatment is equivalent to losing almost 4 years of your life. So every minute really counts. Getting to the call, getting the person in the ambulance, getting to the hospital. And we talk about, just like in trauma, the golden hour of stroke. So if we can recognize stroke early and get patients to treatment, that's extremely important. Some people are using stroke ambulances to try to decrease this time. But the bigger problem is that, unlike heart attacks with chest pain, stroke doesn't hurt. And sometimes the person having the stroke doesn't recognize it. So it's really getting access to care that matters. So kind of just, you guys know this better, but if a stroke is recognized, and we use either BFAST or FAST for face, arm, speech, time to call 911. So that's kind of the AHA marketing to the community, that people call 911 or show up in an emergency room, and then EMS can take a patient to either a community hospital, a primary stroke center, or a comprehensive stroke center. So I know you guys are sitting at Lone Peak right now, so let's use the example of, if a patient has a stroke and calls 911 close to Lone Peak, what kind of happens in our system. So they would show up at Lone Peak. They would be evaluated in the emergency department by a neurologist on telemedicine, and we would give tenecteplase, the IV lytic, and that is a better form of IV TPA because it can be administered as a bolus. Then if they have a large vessel occlusion on imaging, they would be transferred to St. Mark's to the Comprehensive Stroke Center. We're very fast in doing that. And certainly, you know, the big player in Utah is obviously Intermountain Hospital. And from my understanding, if a patient is imaged, say in Utah County, and then transported to Intermountain Medical Center, that patient will be imaged again, and there can be some additional delays. So one nice thing that we do in our system is we share all the imaging, and we actually have an app for that using AI. And so we know, and we've already have the team waiting at St. Mark's if we're going to do a thrombectomy. So this is a graphic showing a blood clot here in the middle cerebral artery on the left. So this person would have speech deficits and paralysis of the right hemibody, right-sided facial droop for this left-sided clot. And while the clot is in there, these small lenticulostriate arteries are end arteries, and they're blocked, and those will probably never come back. But the rest of the brain is actually backfilling from collaterals over the surface of the brain while this clot is here. So some people stroke fast and some people stroke slow. So when you guys get a positive CStat score in the field where it looks like they've got a severe stroke, it is completely appropriate to bring them to the closest freestanding ED or to Lone Peak. It's the same Blue Sky neurologists and our same radiology team. So in the emergency department, they'll do an exam, an NIH stroke scale, and that gives us, you know, a 0 to 40 score. And most large vessel occlusions have more of a 10 to 15 range. And so we're calculating that NIH stroke scale, and this will be done by the ER physician and the neurologist. But this last known well piece is really critical for giving tenecteplase. And a lot of times you guys can only obtain that in the field. If you're a little unclear about the last known well, I'd actually use the earlier time, because then we can get patients either to tenecteplase or to clot removal. So if it's 4 hours or 6 hours, I would kind of hedge on using the shorter time so that we can give patients therapy. So we always rush them to the CT scanner. We just stop at the launch pad and take them and look for bleeding. That needs to be ruled out before we give IV tenecteplase. And then we do a CT angiogram where IV dye is injected in blood vessels, and we're looking for this blockage on CT scan. So we talk about ELVO, large vessel occlusions, and medium vessel occlusions. And these are the ones we can remove in the IR suite. Sometimes we'll do a perfusion imaging, and this shows us using contrast dye if there's brain to save versus already dead brain. And this is available throughout our system. So all of that imaging immediately goes to the radiologist and neurologist's phone. So when I'm on call for thrombectomy at St. Mark's, I'm on call for hemorrhagic and ischemic stroke. And every time the computer sees a blood vessel blockage, it pings my phone and wakes me up. Then I'll call the emergency room, say at Lone Peak, and say, hey, what's the last known well? You know, is there work for us to do? And if yes, the patient goes either in helicopter or ground transport, and then my team's coming in to meet the patient at St. Mark's. So when you drop a patient off too, then we ask that you stay in case they need to be transported. So a CT angiogram is a picture like this. It's a CT scan. So the feet are coming out towards us, and then here is that white arrow pointing to a blockage of the middle cerebral artery. So even though it really looks like you've got blood vessels on both sides here, this is a very severe stroke. It's a right-sided stroke. It have left hemiparesis, but it's a proximal middle cerebral artery occlusion. When we see this, the AI app in our phone pings us, wakes us up, and then we're immediately mobilizing our team. We'd rather call off our team and send everybody home than miss one of these strokes. In Australia, about 50% of people with a large or medium vessel occlusion get to an IR suite and have their clot removed. But in the United States, all comers, it's only about 5%. So we have a lot of work to do. Our technology of getting these clots out of the brain is excellent. We have little vacuum cleaner aspiration catheters and stent retrievers, and we can get those clots out. But what we can't do somehow is get the patients to the hospital. So even though we have excellent EMS in the United States, we have different systems competing in different hospitals, and for some reason we just get a lower hit rate than other countries. So there's a big room for improvement and a lot of lives saved here with the work that you guys are doing more than the work we do. So the treatment for an acute ischemic stroke, the stuff that we do in the hospital is over here. We remove the clot in IR. Sometimes we need to stent the carotid artery, or rarely the vessels inside the head. And sometimes these patients still need surgery at a comprehensive stroke center. They need to have their skull removed so the brain can swell to protect the other side. They can have some of the dead brain removed. So medically, though, we have blood pressure management. And I'd like to kind of open this up. Has anybody transported a stroke recently? And what did the ER docs tell you in an inter-hospital transfer to keep the blood pressure at?
We're unmuted, so you guys can.
Somebody be brave. I'm here in my sweatshirt, being brave, talking to you. So blood pressure management, where do you want your stroke patient's blood pressure in transport?
Speak up.
100 systolic.
Say that again.
100 systolic.
Yeah, that's way, way too low. So we need the blood pressure to come all the way across the hemisphere, say from the anterior cerebral artery to the middle cerebral artery. So even if they've gotten tenecteplase, I want their blood pressure more like 180. So if the ER doctor tells you to start nicardipine or bring their blood pressure down, that is not the right treatment. Somebody having a stroke will push their blood pressure up, and that's autoregulation, and we want to let them do that. We don't want them to bleed in their head secondarily. So, in an older person, I start getting a little nervous about 180, especially if they've had tenecteplase. We want that blood pressure as high as possible. After their clot's removed, we use medicines to bring the blood pressure down. But if you show up with somebody on your gurney having an acute stroke prior to clot removal, I'm going to actually start them on Levophed and press their pressures up to more like 180. If they've gotten tenecteplase, we go like 160 to 180. But like a younger patient, we would let them ride up to 200, 220, and sometimes they'll push. They can really hang on and keep their blood pressure alive through collaterals if their blood pressure is high enough. In the hospital, we do good blood glucose control, and there's evidence that that control in the immediate stroke setting is going to give you a better outcome. There's over many years, there's been a lot of interest in neuroprotection, that we recognize somebody having a stroke and we can give an IV medicine. And there's been studies of many, many compounds, and this has not really come into practice or to fruition. It's not working, but many neuroscientists are still hoping to find a neuroprotectant so that we could keep stroke patients going longer till we can remove their clot. In the hospital, there's other medical therapy, PT, OT, really invaluable. And then even medicines like antidepressants, selective serotonin reuptake inhibitors can help neuronal regrowth and improve outcomes after stroke. There's emerging rehab technologies where people use like video game virtual reality to compensate for their deficits. And there's more and more technology to help stroke patients. So this used to be a devastating disease with lots of disability. It still is, but we have also incredible outcomes. And this is a very exciting time to practice in this field. So somehow now I don't have my slides to go forward. Since I'm not able to
Can you click in your screen and see if it'll catch it again?
oh, I'm trying.
Okay.
It's gonna, it's like completely frozen. That's nice. All right, here, I can bring up this browser window. So one thing I did want to show is this article was published earlier this year, just in the New York Times. And my sister actually sent it to me, and it's amazing. It really shows what we do in the cath lab and how powerful this is. So if you guys are bored and you ever want to be sort of inspired, this really made me feel so good about doing the work that we do. That taking clots out of the brain is probably one of the most revolutionary treatments in all of medicine. And this shows somebody working in the cath lab, and this looks very similar to the way we do this. This photograph is from a very good hospital in Alberta, Canada, and they use cloth gowns. We don't get those here in the United States, but we put a tube here into the groin or sometimes the wrist radial artery. We're looking at a screen while we're removing the blood clots and injecting dye. So this shows the middle cerebral artery here, And then this shows the catheters going up into the brain. So this is exactly what our stroke setup looks like in real life. There we go. So here's another image of what an angiogram looks like when we're working to remove the clot. So the white arrows show the blockage here before mechanical thrombectomy or clot removal, and then after, and we get those nice middle cerebral artery blood vessels coming back up. So conventional angiography, where we're inside the blood vessels, inside the arteries with a catheter, is the gold standard for characterizing this pathology. And this is available in the HCA system at St. Mark's, at Ogden Regional. But again, any outstanding freestanding ED where we can give tenecteplase or Lone Peak, we can do the imaging and get these patients to definitive treatment. And we're very quick with that. So this is a graphic of the clot removal. And this is a technique that some of my partners use, and I don't actually use this technique, but we bring a catheter and block the carotid artery with a balloon guide. Some people are faster with this than me, so I don't actually use the balloon guide. And then we use a vacuum cleaner catheter and a little retriever to take the clot out. So that's a graphic of how that's done. This is closer to the technique I use. So this stent thing is called a stent retriever, and then we use that in conjunction with a vacuum cleaner catheter that's hooked to aspiration with a pump and pull the clot out. So this is also showing a balloon guide. Some of my partners do this, but I tend to try to just suck the clot out with a catheter. And we've gotten really fast. Our average procedure times are maybe 20 minutes, but we have cases as fast as 6-7 minutes from when the patient gets on the table to when their blood vessels are completely reopened or recanalized. So we're very fast with puncturing the groin, getting our equipment up. So this is a case I did recently, and it really hit home. I'm kind of a new mom. I was going to say a young new mom. I am not a young new mom. I'm a very old new mom. But when people have strokes after they have a baby, it always really gets to me. So I was asleep, wasn't on call, and my app in my phone went off using our AI software that there was a patient that had a blockage, a large vessel occlusion in their head. And I looked and I was like, 34, really? Whoa, I'm going to go in and help and do this case. It's 2 a.m, but you know, a 34-year-old. So when I got there, I realized she was 1 month postpartum with a brand new baby. And later I came to find out that she was having some neck pain. But when I met her, she was just eyes wide open, really freaked out, couldn't talk at all, complete aphasia, no speech, and complete right hemiparesis, couldn't move her right arm, couldn't move her right leg. She got tenecteplase and was transferred in an ambulance with a ground transport to St. Mark's. So because our phones had gone off and we'd had the imaging at her referring center, and I think this was from Timpanogos, I can't remember, but we had the whole team waiting and we were ready to go. So we're very fast. We did not re-image her. We just got her on the table and we did a thrombectomy. And I don't have the pictures here to show you, but she had torn her left carotid artery and dissected it. And a big clot from her neck had embolized into the brain. We got that all out, and then her dissection healed on its own. I saw her 6 weeks after she had her procedure at St. Mark's. She was home taking care of her baby, essentially normal, able to do all of her daily activities, and the dissection had healed. I thought originally I might have to stent it. It was a very ugly looking dissection, but it healed, and after 6 weeks she looked great. We put her on anticoagulation with Eliquis and we're able to stop that and put her on aspirin. She's doing great, and we're really, really proud of that. And this kind of highlights both that young people can have strokes and that we can help them. So when I talked to her in my office after this had happened, she had had symptoms previously. Her neck was hurting and she had been walking down the stairs with her baby and felt weak on the right. She said, I had a migraine and, you know, my arm wasn't working like 3 days before she came. So that was not actually a migraine. It was her stroke. Then she asked her mother-in-law to massage her neck because it was hurting from the torn or dissected artery. And probably that was what massaged the clot into the brain. So just really devastating. And had she not gotten a thrombectomy and gotten care, you know, she wouldn't have been able to live independently and probably would have been in a nursing home with her husband raising 3 kids, including a 1-month-old baby. So just a really crazy story. So the length of the blood clot actually determines whether tenecteplase can open a vessel. So this is kind of a complicated graph, but if the blood clot is only 1, 2 millimeters, 3 millimeters, most of those blockages will actually open with tenecteplase, or this is older data from old school alteplase, but tenecteplase will do a little bit more. But as the clot gets to be 7, 8 millimeters, those really don't open with tenecteplase. We still give it, and it's important to get those patients to a place that can give them tenecteplase as soon as possible, but really they need clot removal. So these longer clots, they need to be taken out with IR in the cath lab. So we're still faster if we give tenecteplase at a freestanding or at Lone Peak, for example, and then ground transport the patient to St. Mark's. Because I think what we do better is we are the only system in Utah that uses tenecteplase, which has a lower intracranial hemorrhage rate and a better administration time because it's a bolus, and it actually opens blood vessels a bit better. We also have already seen the imaging from anywhere in our system, so we don't need to repeat that, and we have the IR team waiting for the patient, and that's very unique. So we're able to be fast with getting these clots out. And these big ones pretty much need to come out in IR. So anything less than 5 millimeters might open with TPA, but big ones over 7 millimeters, they need to be removed. This is my favorite slide, and I've been showing this for almost 10 years now. But in 2015, all these big papers came out proving that clot removal or mechanical thrombectomy was effective. And it took a long time actually for that science to be proven. It seems obvious, but for some reason we can't do the right studies. But I'm sure you guys take a lot of STEMIs and then there's lots of cardiologists doing lots of procedures. So nothing against cardiologists, they save lots of lives, but a primary coronary intervention or treatment for a STEMI, you have to do somewhere between 20 and even up to 80 of those procedures to save one life or make one person functionally independent. So it's a lot of cath lab trips. So most patients that go to the cath lab aren't benefiting from the therapy. It's 1 in 20 up to 1 in 80. In stroke, the numbers are much, much better. So various studies show the number needed to treat 1 in 3 to 1 in 8. So for every 3 clots I take out of the brain, one of those people is going to be alive or functionally independent that would have been dead or nursing home bound. And so this is why this is probably the most efficacious and impactful intervention in all of medicine, more than antibiotics, more than gallbladder surgery, more than cardiac surgery, because of these numbers where we need to take these clots out. So really the key now is there's lots of good operators, lots of good hospitals, but we've got to identify these patients in the community and we have got to get them to the hospital and get closer to those numbers in Australia that are more like 50%. 5% is just really unacceptable to offer an intervention that has this degree of success, and nothing has these numbers. The other thing that happened more in 2018 is we were able to extend the time window for stroke. So there are studies showing that between 6 and 24 hours, if we use advanced imaging, specifically CT perfusion, which is now widely available at our hospitals, a lot of patients that have been blocked even for 21 hours, we can open those blood vessels and they still do well. Because we're selecting patients with imaging that still have brain to save, a live brain, we actually have better numbers needed to treat, more like 2, 2.5, or 3, that are just as good as the clots we get out early. Not everyone will qualify at 20 hours, but they need to be at a center that can get that CT perfusion imaging. And then so there's 2 types of AI competing software that are apps on our phone. One is called Rapid. This is the one I used in New Mexico in my last job. And then we use VizAI. And it's really good software, and it's really good communication software. So that's how we know. And I have definitely treated people beyond 24 hours. I treated a 12-year-old in New Mexico at 3 days, but his imaging showed that there was brain to save. And so being in a comprehensive stroke center, we don't level 1 stroke things in our system at like 21 hours, but those are still an emergency. And once that imaging is going off, you guys may not see us, but we're working in the background to get any patient to the right center that needs to be treated, either at St. Mark's at the Comprehensive Stroke Center or transported. So just because they're 21 hours out, or even maybe, a day and a half out with a severe stroke, sometimes we can still help them. Right now we use VizAI, the app on our phones, just to kind of communicate between radiologists, neurologists, and sometimes ER docs, and we communicate in real time and look at those. And we even use that to communicate between different docs. But some states do allow EMS to access VizAI, And this is something that HCA, St. Mark's, et cetera, have purchased Viz AI for all the hospitals. And there's some concerns about patient safety or patient privacy. So we haven't shared those with EMS, but that's something that we're looking into, so that if you guys could actually kind of look in the app in your phone, you could download it for free and see what happens to your patients. But we also welcome you if you transport a patient from one of our sister hospitals into St. Mark's. If you have time, I know you guys are busy, but please come into the cath lab, watch us, and interact. You know, we're focusing on the patient, but we want to give you feedback and let you know how folks did. I used to work in EMS a long time ago, and I think that was a frustration of a lot of the medics that I knew, is that they would drop a patient off and not always find out what happened. But we'd love to share that information, and obviously Ross and Holly can get you that information too. But if you want to hang out, and we have control room, usually somebody has food in there, and we'll feed you and kind of let you continue to participate in the care of the patients. So I want kind of to send out this call to action that, you know, a lot of people in their 90s that are at a nursing home, somebody will call and it's like a questionable stroke, and it's really hard to figure out who to transport. But when they have those severe symptoms of stroke, they can't cross midline with their eyes, they can't talk, or they can't move half their body. That's probably a large vessel occlusion stroke, and we need to get them to imaging. And it really doesn't matter what hospital they're at, but I think there is some advantage in bringing them into the HCA system because of that shared imaging and the activation of the team. So you may be standing there in the CT scanner and it seems like there's only one ER doc, but we're looking at all that imaging in our phone in the background, organizing the transport, and then getting our team ready at the receiving hospital at our spoke, or at our hub rather. So these patients need to be transported and they need to be identified. So a lot of our jobs is to sort of educate our friends and family in the community so that we can get more of these clots out. It's not as good kind of on the video, but I was hoping to, that's all the slides I have. But if you guys have questions or cases, I would love to sort of share any personal experiences with transporting stroke patients in Utah.
No questions here?
What's more effective, thrombectomy or the TKA?
So I'm sorry, say that again.
What's more effective, TKA or thrombectomy?
TNK.
That's a good question. Yeah, so it depends. For a small clot, alteplase or tenecteplase, the lytic IV medicine will open many of those, and thrombectomy works better for large vessel occlusion. People have recently done studies in Europe comparing thrombectomy alone or thrombectomy plus tenecteplase, and there is some evidence that tenecteplase will continue to break up smaller clots, so they are synergistic and they work together. There are some downsides of having tenecteplase recently administered when we do our groin puncture, just a little bit higher risk of bleeding, but actually the bleeding into the brain rate is lower. And so we know now that tenecteplase plus thrombectomy is a safe and effective treatment and may be beneficial. But after 4.6 hours, we can't give tenecteplase. So the only option for those patients is thrombectomy. The technology is getting better and better, though. You know, in a young patient with a severe deficit, even if the clot is way out in what we call the M3, we can navigate out into there and get out these medium vessel occlusions. So thrombectomy, as long as we're able to remove the clot, is very effective.
The reason why I asked that is we had a training here like three months ago where they, I guess, convinced me that we always are taught to go to the most appropriate facility with our patients, but they said the standalone EDs and this ED would be better to bring stroke patients than going directly to St. Mark's, where they could get preventative care. Your thoughts on that?
Yeah, I'm really glad you brought that up, because when I moved to Utah a year ago, I was kind of like, really? Like, I went to visit some of these freestanding EDs and it's like an ED doc and a CT scanner and a little box. I'm like, can they really do anything? I'm like, this can't be faster. But Dr. Grant's, a wonderful neurologist at St. Mark's, was like, no, look at our numbers. And then I saw it in action. I've seen people from Taylorsville. I've seen people from Pleasant Grove, freestanding ED, and you have everything you need there. So you take the patient in, they get their CT and CTA. So we know if they have a large vessel occlusion, they have tenecteplase, they have an ER doc, and there's not kind of the chaos of a big center like Intermountain, St. Mark's, the University of Utah. and they're able to get Tenectaplace on board, and then we see all the imaging. So we've already called in the IR team, and then as soon as that patient hits the launch pad from the freestanding ED to St. Mark's or Ogden, if they're coming from north, then we're already ready, and literally the neurologist repeats the NIH stroke scale. It takes like 2 minutes, and then we go straight to IR. So we're very fast with that, and it seems like you're dropping a very sick patient off at like a box with a CT scanner, but that's all you need. You need a box with an ER doc, a CT scanner, and Tenectaplace, and we're actually faster because we're sharing all that imaging using AI. So
61.
I've been proven wrong as well. It works.
61 raised their hand. Do you have a question? If you want, unmute.
Yeah, I'm just wondering, you mentioned that the patient would have to get re-scanned if they went to like IMC, but when you transfer them, won't they be re-scanned also to see what the progress of the stroke is?
No, we don't do that because we want to save time. So there are settings in which we would get a new CT scanner. And this is a little technical radiology stuff, but because we meet the team, unless they look like they've bled into their stroke and, you know, they're obtunded, they're not waking up, they have a headache, and they've deteriorated after Tenectaplace administration, we just go straight to IR and get the clot out. There's no reason to waste more time and get more imaging. In our opinion, we think that the clot needs to come out, and we actually can perform a CT scan on the IR table. So every once in a while, if somebody really doesn't look right, like they've bled from Tenectaplace, I will do a CT scan and then say, no, sorry, they bled. We're not going to do the clot out, take the clot out. But 95% of the time, we do not need to re-image them. Some centers will re-image after a 90-minute transport time, but usually we're actually able to avoid that in Utah. Between air and ground, we're pretty good at getting patients there faster. So it's much more important to save those neurons and just get the clot out. We image them after to see how good of a job we did, but it's also clinical, but we do not re-image them. And unlike, I think, other centers, we have the IR doc and the neurologist meet the patient. So we've already seen the imaging. Like if you were to transport a patient, say we have this happen from Timpanogos to Utah Valley, people are like, it's only 10 minutes away, it's way closer. That's better. But they can't see the imaging from Timpanogos. And so they do have to repeat it at Utah Valley. And then once they re-image the patient, then they call the team in. So it's at least another 45 minutes. Whereas if the patient goes from Timpanogos to St. Mark's, we've already seen the imaging in our phones, and then the team is there to meet the patient. So it's only the transport time, but no re-image and then call in. So it saves a lot of time to keep them in the system.
Thanks.
Yeah, no, I love that idea about the freestanding EDs, and if you guys have issues ever, please get those to Ross and Holly, or just back to us, because Dr. Grants and I are very involved with the administration. We want to know if there's any issues, like you're not getting, you bring a patient that you think is having a severe stroke and there's not somebody to meet you there, or it just doesn't feel like the process is working, because we take that feedback extremely seriously and make changes, and we talk about it in our stroke meetings, and really try to get better.
I mean, if we're bringing the stroke patient here, they get the Tenectaplace. We should end up getting in their facility. We should just pretty much anticipate to stay right there because they're going to be in our hands.
Yes, that's a great question that's being brought up. If Draper brings a patient in here that's a stroke patient, they're getting Tenectaplace. Obviously, they should just kind of anticipate hanging around and being able to take that patient straight to St. Mark's right after, since Draper does our inner facilities for our.
Exactly. Yeah. Don't drop and leave, because especially if they're having a severe stroke, just hang out, because they're going to be retransported. So getting the exam and the CT scan, CTA, it really can take, 10, 15 minutes. The neurologist is on tele examining the patient. And then, that patient may need to turn and just go right out the door to St. Mark's. So we do ask that you wait, and that saves an enormous amount of time too. And there's some other ways, like Ogden, when somebody has a severe stroke scale in the field in northern Utah, they're dispatching the helicopter to like Brigham City or Logan to meet that patient, because we know that they're going to need, even if they don't need thrombectomy, they may need surgery for their stroke. They're going to need a higher level of care. And so we'd rather have the helicopter there to transport them. But for ground, like that Draper to St. Mark's, You drop your patient off, let them get their imaging, get their tenecta place, and then you're going to immediately turn around and take them to St. Mark's. And even if they don't have a large vessel occlusion, but if they've got an intracranial hemorrhage, we can take care of that at St. Mark's. If they have a severe stroke that needs surgery, even, you know, a carotid stenosis, there's a lot of other things that we do. Like we have a neuro ICU doc at St. Mark's. So you're going to want to get them imaged and treated within that golden, you know, hour of stroke in an ideal world at Lone Peak, and then get them to St. Mark's. So please wait.
And you think the benefit of us getting them here for that connect place is better than us just hauling ass to, excuse my language.
No, it's
Just-
fine. I've heard that word before. I'm a big one.
They're just getting them to St. Mark's.
Yeah, so I didn't believe that. I was like, oh, can we just please bring these patients to St. Mark's? But I have been proven wrong. And now I'm prepared. So when they're imaged at Lone Peak or Taylorsville or, you know, any freestanding ED, I've already seen the imaging in my phone. So I have a plan. And so that time is more parallel processed. You really actually want to take them to the closest place. It seems weird, but we've got it on the back end. Like we're looking at the imaging, we are figuring out what needs to happen. So while you're driving between Lone Peak and St. Mark's, we are calling the team in, opening our catheters, making the plan. Whereas if you take the patient straight to St. Mark's and image them, then I don't get the call, and then it takes my team 30 minutes to get in. So you're saving like 30 minutes because you're driving and I'm prepping my catheters at the same time. So that's why it's faster. That makes
The
sense.
same situation would happen with the West Valley ED and West Valley Fire. They do the urgent transports out of there. With Taylorsville and with Harriman, we're actually using Air Life to come in and pick up our patients for those urgent care ones like that and transport them by helicopter.
Yeah, and sometimes the helicopters can't fly and stuff, but I mean, coming from New Mexico, like Santa Fe is an hour ground drive away from Albuquerque, and I would have 8-hour transports, and it was just horrible. Like young people would come in with a stroke in Santa Fe, and I could not get them to Albuquerque. Like it literally would have been faster for me to drive to Santa Fe, pick them up, put them in my own car, and drive them back. But Utah surprises me. Like I think sometimes like, oh, I have 5 minutes to take a shower. I do not. I have to get my butt to St. Mark's to meet those patients because I don't know whether they're coming ground in a helicopter, but they're fast. Like Payson even, it's pretty fast. So I'm always blown away. Utah seems like they have it together with EMS.
That was great. Any other questions online or in here? One thing you said in a previous class that we were talking about because we talked a lot about ischemic today. With your hemorrhagic strokes, those are ones that if there's no midline shift, there's no pressure building up, you've got time to sit and wait on those and work on the blood pressure. And you even mentioned one time that you got the notice in the middle of the night on a hemorrhagic and you said, oh, I'll see you in the morning, right?
Yeah, I mean, that's true. Like, let's say there's a subarachnoid hemorrhage from an aneurysm rupture. We image those patients and there's neurocritical care and neurosurgery available, but we don't fix aneurysms at night because it's actually more dangerous. So, you know, sometimes they need a tube to drain fluid, but not most people. So let's say there's just a bleed in the brain. As long as they don't need to go to the OR, we're going to image those patients, figure out what caused the bleeding. A lot of them get medical management. They kind of sit in the ICU. So they're seen by a neurophysician, you know, right away, but they don't always need me. So usually, you know, thrombectomy and ischemic stroke, like I'm driving as fast as I can in my car and, you know, don't change. I just go to the hospital. But hemorrhagics, I usually have some more time. I look at all the imaging and I tend to, if they need me, fix those in the morning. So.
Good.
Yeah, most hemorrhagic stroke, we actually have more time. But I mean, all of these should be treated as if they're ischemic because that's where we have the time-sensitive intervention. So, and I know that people, EMS goes in and there's like ER nurses that are kind of roll their eyes and be like, oh my gosh, you guys, this is not a stroke. And but we want you to overcall stroke. I would way rather you accidentally like identify some drunk guy as having a stroke and then we get the imaging, it's not a stroke, fine. But if you call the strokes and activate the process, and then we'd always rather like you overcall it than undercall it. So on the back end, the physicians that treat stroke want you to overcall stroke. So if you're suspicious, just call it and then let us rule it out. But we want those patients like lights and sirens to the closest place we can treat them.
All right, not seeing any other questions online. If you guys don't have any. Good. Dr. Sorte, thank you so much today. This has been great, been informative, and I appreciate your time you've given to us for this. And yeah.
Thanks so much for having me. Hopefully next time it'll be in person and more interactive. We can always like bring devices in, and I think that's really fun for people to like see the catheters, see the stent retrievers that we move clots. So hopefully we can set something up where it can be a little more interactive and hands-on.
Great. We'll bring you back.
Okay, thank you guys so much for listening and accommodating my video presentation. Appreciate you.
Thank you so much. Appreciate it.
Bye.
Thanks everybody online for joining today, and I appreciate you being here.
Ooh.